Hello, I'm Vignesh, a clinical fellow currently working in care of the elderly department at the Royal Gwent Hospital in Newport. Thank you for joining us today and for your interest in our poster. I'm going to talk about a quality improvement project that my colleagues and me have done in the geriatrics ward at the Royal Gwent Hospital. So let's get started. I'm sure many of you would have noticed that delirium, falls, urinary retention and constipation are common reasons for elderly patients being admitted into hospital. And many of these patients are on multiple regular medications, a few of them particularly known to have anticholinergic side effects. I would like to highlight two important terms: polypharmacy and anticholinergic burden. Polypharmacy is characterized by the use of 5 or more prescribed drugs per day. Anticholinergic burden refers to the combined impact of taking medications that have anticholinergic effects. As we can see from this interesting data, exposure to medications with anticholinergic burden increases the risk of falls-related hospital admissions, increases the risk of dementia, and is also associated with a significant increase in mortality in elderly patients. Keeping this in mind, we undertook this QIP with an aim of improving awareness of anticholinergic burden among doctors, which in turn can promote routine medication review and deprescribing of medications to reduce polypharmacy as well as to decrease the anticholinergic burden. We started off by collecting baseline data over a 2-week period, wherein we calculated the anticholinergic burden on admission and on discharge using the AEC tool, the anticholinergic effect on cognition tool. We then circulated emails to all doctors working in geriatrics and pasted posters in all geriatric ward with an aim to improve doctors' awareness. Data was then collected over a 2-week period to see if this intervention had any effect. We then delivered a presentation which was attended by all doctors in care of the elderly, and also pasted stickers on patients' drug charts and on their medical notes in order to encourage doctors to review medications and to consider deprescribing. The final data set was collected after the second intervention. A questionnaire was also sent out to all doctors before and after intervention to assess their awareness of anticholinergic burden and their utilization of the AEC tool. This is the poster that we prepared which went on the wards. On the left are some of the common medications that we come across on patients' drug charts, and to the right are some of their side effects. On the top is a drug chart sticker that we designed, which was pasted on the front page of all patients' drug charts, regardless of their AEC score. And below is the sticker, which is slightly bigger in size, which went onto the medical notes of patients with an AEC score of 1 and above. This is a QR code which takes you directly to the anticholinergic effect on cognition tool, which is also available if you type in MediCheck Calculator on your browser, spelled MEDICHEC. Please feel free to scan the QR code, which should take you to the link to the AEC calculator. Here you could enter the medications and it would calculate the anticholinergic burden and its side effects. The table on the top is a snapshot of some of the common medications prescribed for urinary incontinence. We can see that oxybutynin has an AEC score of 3, tolterodone has a score of 2, solifenacin a score of 1, and darifenacin scoring a 0. Yes, now each of these medications has its own indications, mechanism of action and side effect profile, but we must always consider deprescribing medications, or if not able to, we must try to switch to alternative medications having 0 or lesser anticholinergic burden. Similarly, the second table lists out some of the common antiemetics and their anticholinergic burden. This table lists out the common antidepressants, and we can clearly see that almost all of these medications have anticholinergic burden to some extent, amitriptyline being very significant compared to others. So moving on to the analysis section, We had collected data on polypharmacy, the medications the patients were on, and the medication review that was carried out. We noted the names of medications that were deprescribed and calculated percentages of reduction in anticholinergic burden through the various cycles of the QIP. Just to touch upon the significant findings and key takeaways. The number of patients with an AAC score of 3 or greater than 3 were reduced during the second and third data collection, and the percentage of reduction was greater than 5%. Amitriptyline, mirtazapine, sertraline, cyclizine, and sulfanisin were the most commonly deprescribed medications with anticholinergic side effects. A crucial part of the QIP was to increase doctors' awareness of anticholinergic burden, and we had very promising results in this regard, which was evidenced by the questionnaire that was answered by the doctors before and after the interventions. Before the project, doctors were aware of some of the common medications with anticholinergic side effects, but as a result of these interventions, clinician confidence in identifying these medications almost doubled. Less than 10% of the doctors were aware of the tools that were out there to calculate anticholinergic burden, like the AAC tool, and our efforts have ensured most doctors are now aware of these calculators. The questionnaire even showed that roughly 3/4 of the doctors were now utilizing these tools in routine practice, which was almost nil prior to us starting this audit. Again, I have discussed most of these findings already. It was interesting to note that most patients whose AAC score was 3 or greater than 3 was due to amitriptyline, and not very surprisingly, this was also the most commonly deprescribed medication. Many patients were also on mirtazapine, having an AAC score of 1, which was the second most commonly deprescribed medication. Right, now we're approaching the end of the presentation. So this project has effectively increased clinician engagement with anticholinergic burden assessment, leading to improved medication management and suggesting that educational interventions and review prompts were beneficial. We felt that stickers on the drug charts and medical notes is a very effective way of encouraging doctors to review medications. This can be done simultaneously by doctors with the help of pharmacists on the ward. Sustaining the momentum generated by this QIP and further integrating anticholinergic assessment into routine practice will be key to driving long-term reductions in anticholinergic burden and improve patient outcomes. I thank you all for joining us today. I hope our poster presentation has enlightened you all about the significance of anticholinergic burden in elderly patients, and we encourage you all to try and incorporate this in your routine practice. Once again, thank you very much and enjoy the rest of your day.